Good morning all. Today's topic is aggressive periodontitis. This lecture is for third and final year B.D.S student. And the important questions are here on the screen. There are long questions and short note from this topic. Now coming on to definition. Aggressive periodontitis comprise a group of rare, severe, rapid progressive form of periodontitis often characterized by early age of clinical manifestation and a distinct tendency for cases to aggregate in a family. Now, again discussing the keywords. It comprises a group of rare. Rare means it is not normally seen. A severe, rapid progressive form of periodontitis that is seen in early age. It is having earlier age of clinical manifestation and tendency for cases to aggregate in the family. That means this disease, it is running in the family. Coming on to the historical background, the disease was named in 1923 as diffuse atrophy of alveolar bone. In 1928, it was named as deep cementopathia. In 1938, it was named periodontitis marginalis progressiva, and later on juvenile periodontitis, and the recent terminology is aggressive periodontitis. Clinical features: distolabial migration of maxillary incisor, diastema formation, mobility of maxillary and mandibular incisors and molar, sensitivity of denuded root surface, deep dull radiating pain during mastication, and periodontal abscess formation. Radiographic features: vertical bone loss around first molar and incisors, and arc-shaped bone loss. Arc-shaped bone loss extending from distal surface of second premolar to mesial surface of second molar. The bone defect is wider than it is seen in chronic periodontitis. Moreover, mirror image appearance will be there. Mirror image means the same arc-shaped pattern will be there onto the opposite side. Common feature as given by Lang in 1999. Except for the presence of periodontitis, patients are otherwise clinically healthy. Rapid attachment, loss and bone destruction will be there. Next is familial aggregation, that means disorder is within the family. These are features that are considered to be there in aggressive periodontitis. Now coming on to the secondary features. Secondary features that are generally but not universally present. Again, secondary features that are generally present. They are generally present but they are not universally present are amount of microbial deposit are inconsistent with the severity of periodontal tissue destruction. Amount of microbial deposit is inconsistent with the severity of periodontal tissue destruction. That means very less amount of plaque and calculus might be there. Elevated proportion of aggregatibacter actinomycetam comitan, and in some population Porphyromona gingivalis may be elevated. And phagocytic abnormalities, hyperresponsive macrophage phenotype including elevated level of prostaglandin E2 and interleukin 1 beta. Progression of attachment loss and bone loss may be self-arresting. I will be explaining you in detail how the disease is due to phagocytic abnormality and what is hyperresponsive macrophage. Periodontitis is a kind of war. On one side there is bacteria and on other side there is immune cell, and the end result of the war will determine what will be the clinical picture. If bacteria will win, then inflammation will be there, and if immune cell will win, then resolution of inflammation will be there. And in order to get rid of bacteria that is there, the immune cell that are polymorphonucleus neutrophil, macrophages, monocyte, they will try to get rid of bacteria by forming phagocyte, by the process of phagocytosis. And this is a schematic diagram that I have drawn to clear the concept in your mind. So this is a immune cell, this is a phagocyte. And how it gets rid of bacteria? By engulfing the bacteria by forming a phagolysosome. And in this phagolysosome, the bacteria is destroyed. And this is the primary method to remove infection. This is by trapping and killing the bacteria. But before it do so, it need to coat the bacteria with immunoglobulin. The bacteria, it get coated with immunoglobulin for effective phagocytosis. That means immune cell can only phagocytize the bacteria if it is coated with opsonin. And opsonin are immunoglobulin and C3b, a complement. If it get coated with a complement and immunoglobulin, then only phagocytosis is made possible. If there is some defect in opsonization, then this bacteria might not get engulfed by the immune cell, and hence disease will be there. So I have tried to explain in this schematic representation what is phagocytic abnormality. This is bacteria, it is coated with immunoglobulin and complement. This is opsonization. Once the bacteria get opsonized, then only a phagocyte can engulf the bacteria and it can be destroyed. So in aggressive periodontitis, there might be some defect in immunoglobulin or in some process of opsonization. Hyperresponsive macrophage and phenotype, including elevated level of prostaglandin E2 and interleukin 1 beta. Let us see what is this. All the cell of periodontium, when they get irritated by any inflammatory mean or chemical mean, they secrete interleukin 1, interleukin 6, prostaglandin 2 and matrix metalloproteinase. And it will act on fibroblast, lymphocyte and monocyte in macrophages, and in turn they will activate the osteoclast and hence bone resorption will be there. So if macrophages, they are hyper responsive, that means excess of activation of osteoclast will be there and hence excess of bone resorption will be there. How the chronic periodontitis differ from aggressive periodontitis? First is the age. Chronic periodontitis is seen in adult age, aggressive is seen in younger but can also be seen in adult. Rate of progression in chronic periodontitis is slow, but in aggressive it is rapid. This is wrongly written. Chronic periodontitis destruction correlate with the amount of plaque, and aggressive periodontitis very minimum amount of plaque is there. And in chronic periodontitis host response is normal, and in aggressive periodontitis alteration in host response is there. Chronic periodontitis familial aggregation is not seen, but in aggressive periodontitis familial aggregation is seen. Now coming on to classification, localized and generalized. Localized aggressive periodontitis, it is seen in circumpubertal age, near the age of puberty. Robust serum antibody response to infecting agent. What does that mean, robust serum antibody response? That means an antigen that is there in the body, the bacteria that is there in the body, within no time antibody is formed and the bacteria is getting killed, and hence the disease is localized. Robust, that means within no time the antibody is formed and the immune cell, they get control over the antigen that is there, and hence it is localized in first molar and incisor, with localized first molar incisor presentation with interproximal attachment loss on at least 2 permanent teeth, one of which is permanent molar. Burnout phenomena. Initially it was thought that localized aggressive periodontitis gradually becomes generalized aggressive periodontitis over time, but some cases of localized aggressive periodontitis does not progress and get arrested and spontaneously and leading to cessation of disease activity. It was proposed by Rene. That means all localized aggressive periodontitis does not progresses into generalized aggressive periodontitis. Now coming on to generalized aggressive periodontitis. Affecting at least 3 permanent teeth other than first molar and incisor, usually affecting person under the age of 30 years, but patient might be older. Poor serum antibody response, that means the antigen that is there, the poor serum antibody response means the antigen might not be effectively controlled by the antibody. Pronounced episodic nature of the destruction of attachment and alveolar bone loss. Now, poor serum antibody response means the antigen that is there, an antibody response, but antibody cannot control the antigen and hence disease will progress. Etiology: bacterial, genetic and environmental. It's a multifactorial disease developing as a result of complex interaction between specific host genes and environment. Bacterial etiology: it is most commonly associated with gram-negative anaerobic rod, and 90% of which is Aggregatibacter actinomycetam cometan, and the other bacteria are P. gingivalis. What is Aggregatibacter actinomycetam cometan? It is small, short, straight or curved, non-motile and gram-negative anaerobic rod. In culture condition, it grows as white, translucent, smooth, non-hemolytic colony on blood agar, and sometimes white, translucent, smooth colony with star-shaped internal appearance, and which is the characteristic of these bacteria. Now, why this bacteria is so aggressive? So let's discuss the virulence factor of the bacteria. First is leukotoxin. Leukotoxin, as I have already told you in my schematic representation, that it's a kind of war that is going on between the bacteria and the immune cell. So the bacteria try to kill the neutrophil by producing leukotoxin. It destroys human polymorphonucleus leukocyte and macrophages in order to win the war. Next is endotoxin. It activates host cell to secrete inflammatory mediators like prostaglandin, interleukin, and hence if inflammation will be there, then bone resorption will be there, breakdown of collagen will be there, and hence disease will progress. Bacteriocin. It inhibits the growth of other beneficial species. Immunosuppressive factor. May inhibit immunoglobulin, IgG and IgM production. So why IgG is required? It is required for opsonization and hence phagocytosis is made possible. So the bacteria, it inhibits IgG production because bacteria do not want phagocytosis to be there. Collagenase cause degradation of collagen. Chemotactic inhibiting factor. It want to inhibit the neutrophil chemotaxis at the site of inflammation. I have discussed with you virulence factor. Now let us see how the lipopolysaccharide, it will cause inflammation. The lipopolysaccharide, they are liberated once the bacteria dies, and once it dies, it will, from the outer membrane, it will liberate lipopolysaccharide, which will activate macrophage, polymorphonucleus neutrophil, and hence more destruction of collagen fiber by MMP, and osteoclast activation will be there, and hence bone resorption and collagen destruction will be there. Death of gram-negative bacteria. Once the gram-negative bacteria dies, it's the outer membrane, it contains lipopolysaccharide, and this lipopolysaccharide, it is set free in the environment. This lipopolysaccharide, this will act on macrophages, white toll-like receptor that is present on the surface of macrophages, and it will activate the macrophage, which will liberate various inflammatory, pro-inflammatory cytokines like interleukin 1, 6, and hence more of inflammation will be there. The mere presence of Aggregatibacter would have been regarded as an indication for intervention? No. Why? Because there are different serotype of bacteria. Aggregatibacter actinomycetam is there in different serotype A, B, C, D, and E, and only A and B is associated with localized aggressive periodontitis, and A is associated with aggressive periodontitis. So what is this serotype? Serotype means surface antigen. This outer surface of the bacteria, they are of different types, and on the basis of their surface characteristic, the bacteria have different serotypes. That means on the basis of different surface antigen, surface properties, the bacteria is further classified as serotype A, B and C, D. So A and B causes localized aggressive periodontitis and A is seen with chronic periodontitis. Reason for limitation of periodontal destruction in localized aggressive periodontitis. Various hypotheses are there showing the limitation of the periodontal destruction in localized aggressive periodontitis. After initial colonization of first molar, an incisor aggregatibacter actinomycetam comitan evade host defense by production of polymorphonucleus neutrophil, chemotactic inhibiting factor, endotoxin, collagenase, leukotoxin, and after that adequate immune response is stimulated. Bacteria antagonists to aggregatibacter actinomycetam comitan may colonize the periodontal tissue and inhibit further colonization of other periodontal site. This bacteria may lose its leukotoxin producing ability and so progression of disease is arrested. A defect in cementum formation may be associated with localization of the lesion, or root surface may have hypoplastic or aplastic cementum. Now we are done with the bacterial etiology. Now coming on to the genetic basis of the disease. It is autosomal dominant in both African and American and Caucasians and different ethical group. And genetic basis is due to some polymorphism. Polymorphism arises as the result of mutation. All organisms suffer from certain number of spontaneous mutation as a result of normal cellular operation or random interaction with environment. Not all such mutations are repaired and they can therefore be inherited and transmitted from generations. And one such mutation is seen in immunoglobulin. So if this immunoglobulin, a part of this is defective, the opsonization of bacteria, it is getting deferred and hence disease will be severe. I have already explained you how this opsonization, it will help the lysosome, it will help the neutrophil to get rid of bacteria by forming phagolysosome. And if this opsonization is defective, bacteria cannot engulf the neutrophil cannot engulf the bacteria and hence disease will be there. The FCGR2A is most widely distributed of the IgG receptor molecule. It is expressed on all the granulocyte, on antigen presenting cell, platelet and endothelial cell. And there is some genetic polymorphism associated with this which lead to phagocytosis being defective and hence severe periodontitis will be there. Other immunological factor, antibody to collagen, DNA or immunoglobulin. HLA antigen which regulate immune response is elevated. HLA-A9 and B15 has been associated with aggressive periodontitis. Other is environmental, that is smoking, but the mechanism of this is still not clear. Diagnosis is done by medical and dental history, clinical examination of periodontium, radiographic and microbiological examination. Prognosis. When diagnosed early, an appropriate treatment is done, excellent prognosis. In advanced disease, prognosis can still be good if lesion is treated with scaling and root planning and systemic antibiotic and regenerative therapy is done. Poor prognosis due to impaired host response, and these patients they do not respond well to conventional periodontal therapy. Prognosis depend upon the type of disease, whether the disease is generalized or localized, degree of destruction, ability to further control the progression. Treatment: improve oral hygiene, scaling and root planning, antibiotic therapy and periodontal surgery. Non-surgical, surgical and antimicrobial. Non-surgical: patient education, scaling and root planning, oral hygiene improvement, regular recall, maintenance. Unfortunately, the response of the disease to conventional therapy alone has been limited and unpredictable. In surgical, resective and regenerative therapy can be done. Resective is done in one wall defect. Regenerative is done in vertical defects. Regenerative procedure has been successfully demonstrated in patients with localized aggressive periodontitis, and recently enamel matrix protein has shown to have good result in patient of localized aggressive periodontitis. Antibiotic. Use of antibiotic has been suggested as a complement to mechanical debridement in these cases. The choice of antibiotic should be guided by the information provided by the nature of the involved pathogenic bacteria, that is by culture. If predominant gram positive bacteria is there, then augmentin is given. If predominantly gram negative, clindamycin. If mostly anaerobic, then metronidazole, and in some cases combination of metronidazole and amoxicillin is given. Thank you.